back in. We're going to talk a little bit about liver-focused disease control. So I'm Ganji. I'm a surgical oncologist at Cedars-Sinai in Los Angeles. Thank you all for waiting to have lunch, and thank you for Delcath for asking me to speak. So we're going to talk a little bit about something called percutaneous hepatic perfusion, and I'm going to refer to it as PHP moving forward. It's a minimally invasive treatment that delivers high-dose chemotherapy to the liver as a standalone or complementary therapy for metastatic uveal melanoma. Unlike traditional chemotherapy, which is given intravenously and goes to the entire body, to the entire system, percutaneous hepatic perfusion isolates the liver circulation and delivers a high concentration of chemotherapy known as melphalan, and then filters most of the chemotherapy out of the blood prior to returning it to the patient. There's really three main phases. There's the isolation phase, if you kind of follow from right to left. The isolation phase is the point at which the liver is isolated via a double balloon catheter that's placed in the inferior vena cava through a large vein in the groin. The second phase is essentially the infusion phase, or the saturation phase, at which point the chemotherapeutic agent is infused directly into the liver via a catheter in the hepatic artery, which is also accessed through an artery in the groin. And lastly, there's the filtration phase, at which point there's blood that exits the liver. It's filtered through extracorporeal filters, meaning filters outside the body, and then the blood is returned to the patient through another set of catheters. And this is a phase 3 clinical trial for patients with hepatic dominant ocular melanoma. And so there's a few phases to this trial. As most, there's always the screening for eligibility. So for those of you who are seeing your medical oncologists or your surgeons or whomever else, there's an extensive screen that goes on to see that if you would be eligible for the procedure. And then essentially you enroll into the treatment arm and see which of the two treatment arms you may be participating in. And then if you're approved, then you can have these percutaneous hepatic perfusion treatments. Treatments are given every 6 to 8 weeks. And the physician, we have the option of giving treatments up to 6 times within the duration of the trial. So the things that are important to know about PHP is that it's an inpatient procedure. It's repeatable. You may have heard about isolated hepatic perfusion. That's another surgical way that we were able to isolate the hepatic artery surgically, which requires, obviously, it's a little bit more invasive given that it's not through catheters in the groin that come out of the skin and you go home the same day, but it's typically hard to repeat that type of procedure. As we mentioned, the treatment takes place every 6 to 8 weeks. Patients are admitted to the hospital the evening prior to the procedure for preparation for blood work and some additional pre-medication that's required, and then most patients are in the hospital for 2 to 3 days. Some do go home as early as 24 hours post. It really depends on kind of the side effects that you have from the treatment. Some of the key inclusion criteria for the study, and we have, I believe there's handouts in the back that you can pick up that have the key inclusion criteria in the sites. Essentially, 50% or less ocular melanoma metastases in the liver. The liver disease has to be measurable by CT or MRI. That's for us to be able to tell if the treatment's working. If we can't measure your disease, then we don't actually know if the treatment's working or not. So that's the limitation there for the trial. You can have extrahepatic disease at baseline. However, it has to be fairly minimal. If the life-threatening component of the progressive disease is the liver, then there's a little bit more wiggle room there. We expect an ECOG performance status of 0 or 1. What does that mean? 0 means that you're essentially perfectly healthy and you can do anything that you were doing before you were diagnosed with the disease. And 1 means that maybe there's some limitations with significant strenuous exercise. The reason for that is because, remember, we mentioned that at one point in the procedure, we basically filter out a good proportion of your blood, and so there's significant compromise to the body and what the heart can tolerate. So you have to be in fairly good physical shape in order to tolerate that. It's almost like having a stress test. It's okay if you've had prior chemotherapy, radiotherapy, chemoembolization, radioembolization, or immunoembolization, as long as there's been a time between any of those treatments and the time that you're going to start this treatment. Those patients who have had PD-1 immune therapy or anti-CTLA-4 immune therapy just have to wait a period of 8 weeks before receiving this treatment. There's no limitation. And you can go back on treatment subsequently. A few of the key exclusion criteria that are important. Patients who have cirrhosis, which is essentially an element of liver failure where we can actually see changes in the liver parenchyma just based on CT scans. or portal hypertension are not candidates because this is a liver-directed therapy, and so you can imagine if we're giving more chemotherapy to an already sick liver, then we're going to compromise your liver pretty significantly, and it's potentially going to be harmful. Cardiac conditions or pulmonary disease that prevent the use of general anesthesia are a key exclusion criteria. Those patients who are taking immunosuppressive drugs or unable to be removed from chronic anticoagulation therapy are not candidates for this procedure. And patients with active bacterial infections or systemic manifestations of bacterial infections are not eligible until they've essentially been cleared of whatever underlying problem is ongoing. The current participating centers in the U.S. are listed here, and again, we have a handout in the back indicating what these centers are. And these are the participating centers in the European Union. So in the European Union, PHP is actually currently approved for standard use. Here, the FDA has yet to approve percutaneous hepatic perfusion. It's being used on a compassionate care basis and on trial. So we'll quickly go over some of the more recent literature that came out in a collaboration from the US and the UK. This was published in 2018, and this was while I was at Moffitt in Tampa. So if you look here, basically it's a kind of busy slide, but the purpose of this slide is to talk about kind of the best overall and hepatic response in the entire patient population that were treated with PHPs. There was a total of 51 patients that we evaluated. On average, they had about 130 or so percutaneous hepatic perfusions. If you look to the column on your right, you'll see the letters CR, PR, SD, and PD. CR means complete response, meaning that there was no visible disease after treatment. PR means partial response, and by specific criteria at the bottom you see they say something, response rates or by RECIST criteria. So partial response means that you had a response that was 30% decrease in size in the main lesions that we could see. SD stands for stable disease, which even if it's not a response, if we can keep the disease stable, that's something we all certainly like. And then we looked at stable disease for greater than 3 months and stable disease for greater than 6 months, and PD stands for progressive disease. So that's what we would favor not to see. And then if you look at the top, so best response, there was an overall for all patients, because remember we included patients with extrahepatic disease also. And we actually had fairly good numbers of both, of just response overall. So response counted as complete partial response, and that was about 47%. Patients, a good proportion of patients had stable disease on treatment. And then there were some patients that had progressive disease, and we'll talk about the nature of their progressive disease in a subsequent slide. And then similarly, if we look at hepatic response rates, again, they were fairly good. We also wanted to look at best hepatic response by disease burden, because it's not uncommon that patients have multiple metastases and not just one solitary metastasis. And what we found was that there was no significant difference in basically in percentages of response if you had more or less disease in the liver. If you were going to respond, you responded whether it was minimal disease or maximum disease in the liver. And that was something that was important to note, again showing that complete liver-directed therapy with melphalan was useful in all patients who were undergoing treatment essentially. With respect to response rates, so if we say, well, what was the overall response rate in these 51 patients that were treated? That overall response rate was 47%. The hepatic overall response rate was 49%, which was higher. So again, we said we'd talk about it, but one patient, for example, exhibited a great hepatic response, but had progressed systemically, which this therapy does not target. DCR is a disease control rate, meaning all of those patients who had complete responses, partial responses, and stable disease would count in the metric for disease control rate. And 43 out of 51 patients had good disease control rate for a total of 84.3%. The 6-month overall disease control rate was 64%, and the 6-month hepatic disease control rate was 70%. So survival, these are just, always take survival. This is what I tell my patients is, these are numbers, right? And they're averages. It doesn't mean that it applies to you. There's people who far surpass this. But the median overall survival for patients who had this treatment was 15.3 months, which is fairly promising for patients with hepatic metastatic disease, with 1-year overall survival of 64% and 2-year overall survival for 36.8%. This allows us to give you some numbers when we're discussing therapy of how potentially successful we hope it will be. The median hepatic progression-free survival was 9 months. And again, we talked about there was no prognostic value in high disease burden or low disease burden, so it's not as though we have to eliminate patients who have too much disease or too little disease from potentially getting the therapy if they are appropriate candidates. This is something known as a waterfall plot. Essentially, it's another way of looking at response. So if you look at everything, essentially, to the right of the screen, those are patients who had progressive disease here, PD. And these 7 of 51, these people that had very, very small progressive disease rates in the liver, they're the ones that had progressive disease systemically elsewhere. So they had extrahepatic disease at the time of treatment, and if they progressed there, they also count as progressive disease for purposes of this paper. Patients who had stable disease, you see some, they're going downward and some are going upward. We talked about by RECIST criteria, in order to say something is progressing or responding, you have to have a 30% change. So anything under 30%, one way or the other, counts as stable disease. And then again, a majority of patients, you can see, had fairly impressive responses for those patients who had partial responses and complete responses. These are not insignificant. What about the toxicities? So if we looked at adverse events, the main component is really hematologic toxicity, and this is something that's not known with melphalan, whether it's given systemically or in this fashion. Almost all patients had essentially low-grade anemia, and that's why we talked about before we take out the catheters and patients admitted to the ICU and all of these things happen, we monitor to see what are your blood counts doing, right? We want to check your red blood cell counts, your platelet counts, your white blood cell counts, and we support that with blood and additional blood products as needed. Thrombocytopenia, almost 98% of patients had that, so that's a drop in your platelet count that doesn't allow for clotting appropriately. And then you can see that if you look at just the grade 3-4 toxicities for anemia, neutropenia, thrombocytopenia, it's about 1/3 of patients really had significant toxicities immediately after the procedure. Coagulopathic toxicities, meaning hemorrhagic events, bleeding. 20% of patients had any grade of that toxicity, and only 2 patients total out of the 50 had grade 3 or 4 that potentially required more observation or additional transfusion outside of what the typical parameters were. Thromboembolic events, that's basically clotting that's abnormal, that shouldn't be happening. The reason for that is potentially because we talked about we give you blood thinning agents at the start of the procedure to make sure that your blood is thin and it circulates through everything as it should. But at the end of the procedure, before we start to remove catheters, you're given protamine, which is a blood clotting agent and helps reverse the effects of the heparin. So in some situations that did cause potential thromboembolic events. In total, there's 7 patients, or 13.7% of patients who saw that. And most of them were actually higher grade. With respect to cardiovascular toxicity, overall 20% of patients had cardiovascular toxicities. We've discussed the reasons why. When looking at arrhythmias, pulmonary edema, cardiac ischemia, which is essentially what happens when you have a heart attack, low oxygen flow to the heart, or cerebrovascular events such as strokes or things of that variety, they were all less than 10%. And for grade 3 or 4 events, again, they were even lower than any grade. With respect to late toxicity, so what happens weeks and months after the procedure while you're waiting for the next one, the most common complaint was really fatigue. So about 17 patients, or 33%, complained of kind of ongoing fatigue after the procedure. None of these late toxicities or early toxicities were filtered out based on the number of percutaneous hepatic perfusions they had had. So we don't know if this was after the first one or the 6th one. That wasn't necessarily looked at, and there were a subset of patients who had multiple procedures. The next highest was transaminitis. That essentially means that you have elevation in your liver enzymes. And about 30% of patients had elevation in their liver enzymes, which to some degree is anticipated because we're treating the liver with chemotherapy. So we know that that's something that's going to happen. The important thing is that when you looked at grade 3 or 4 transaminitis, that was really only 6% of patients. That becomes important because having persistently elevated liver enzymes may preclude you from getting additional therapies or liver-directed therapies in the future if it doesn't reverse itself. But this was typically self-limiting. The next most common complaint tended to be nausea and then vomiting. For most patients, this was peri-procedural, so immediately after the procedure, there was an element of nausea for about 24 hours that was treatable with medication and typically self-limiting and resolved, and none of those were grade 3 or 4. So in all, we felt that PHP was fairly well tolerated, that cardiovascular toxicities existed, but they were primarily observed peri-procedurally, meaning immediately surrounding the procedure, given kind of the hemodynamic extremes that the patient may experience during the time. There were 4 cases of neutropenic sepsis, so we discussed neutropenia being kind of a drop in your white blood cell count. Sepsis means that basically your body was not able to compensate for the significant drop in the white blood cell count, and it resulted in you potentially getting an infection that your body couldn't necessarily handle with additional support from us. There were 5 cases of post-operative troponin elevation. So troponin is a marker that we measure when we think that someone's having a myocardial infarction or a heart attack. One of these patients had associated EKG changes suggestive of an actual myocardial infarction. And one patient had an association with pulmonary edema. There's multiple reasons that the troponin can be elevated, which is why we check essentially chest x-rays and EKGs and everything else to see exactly what's happening. There was 2 patients who had pulmonary edema without any associated myocardial infarction that required slightly longer hospital stays of 3 days. And then again, bleeding events were common perioperatively in about 20% of patients, but most of them were minor. So these were patients, once we remove the catheters, we monitor you to make sure there's no big bruise forming at the site of the catheter removal or anything of that variety. None of these patients had internal bleeding, which is really the thing that can be a little bit difficult to find and get to. So with respect to thromboembolic events, there was about 13.7% of patients had thromboembolic events within 2 months of the procedure, and here we list the different ones. Most of these were at the sites of some of these catheter site placements. And again, these aren't filtered out to determine whether it happened at the first procedure or second or third. Immediate post-procedure toxicities, we talked about the thrombocytopenia and anemia. Those were the most significant. And transaminitis we also discussed. The other adverse events were fairly mild and self-limiting. So the other important thing to note is the patient selection criteria were fairly strict in this study and similar to what we're currently using for the FOCUS trial. Those patients who had known extrahepatic disease, there's only 9 of them, they were only offered treatment if the extrahepatic disease was amenable to resection or ablation, meaning we felt that if we can control the disease in the liver, then there's something we can do about the extrahepatic disease. So it wasn't patients that had a lot of systemic disease and also liver disease. Similar to the inclusion criteria for the trial, patients had an ECOG performance status of 0 or 1. It was important that the patient had preserved hepatic function, so patients who had liver disease were not offered this therapy. And of all the patients, there had only been 1 patient who had a previous cardiovascular history, and they had had a previous MI 5 years prior who had been cleared by multiple cardiologists before undergoing treatment. None of the patients had bleeding or prothrombotic tendencies. The number of PHP cycles, on average, there were 3 that performed at Moffitt and the patients included in the study, and 2 in the UK. And similarly, as we mentioned, this is a treatment that could serve as a standalone or in conjunction with something else. So 60% of these patients actually went on to receive immunotherapy after completing their courses of PHP, so it didn't preclude them from getting additional therapy. So we feel that it's fairly well tolerated. PHP treats the entire liver, so both metastatic disease that we're able to see and what we're not able to see. The most common side effects tend to be hematologic, and they are manageable and typically resolve on their own or self-limiting. In the current FOCUS trial, which is ongoing here in the US and in Europe, patients are receiving an average of 4 PHP treatments. And as we mentioned just a second ago, these patients can go on to receive additional treatments, whether they're immune therapy or liver-directed specifically. So with that, I'd be happy to take any questions. Yes?
Is this only being used for ocular melanoma or also other liver cancers?
In the US, the trial is currently being used for ocular melanoma only. In the UK, it's being used for cholangiocarcinoma, some varieties of liver cancers, and other treatments, but it's not approved for use in the US for those cancers yet. Yes?
What is, excuse me, what is the recovery like once the patient leaves the hospital? Is it just right back to work pretty easy, or is it because you have something in your leg that, or in your groin that's going to be a little painful, it takes a while?
So it varies a little bit from patient to patient. There's some patients who go right back to what they were doing before. The limitation is typically we did most of these in Florida, so we told them not to go back in the ocean or in their swimming pools for a couple weeks until the site of the catheter placement had essentially scabbed over and healed. But short of that, there was really no significant limitation in terms of what they were able to do. A lot of our patients who were really, ECOG 0 and had amazing functional status, they typically would go back to doing whatever they were doing the following day. Some other patients typically would have they'd be a little bit more tired, a little fatigued, and so they would take some additional time off, generally up to a week, but no more than that really. We generally see you in the office a week following the procedure and check your blood counts, and then everything is essentially kind of monitored throughout that period of time. I would say about half the patients left within a day from the ICU directly, and then another half would stay for an extra day. The people that typically tended to stay, the patients that typically tended to stay were the ones that had significant nausea or discomfort with, GI upset. That they just weren't able to remain hydrated or anything of that variety until everything kind of was filtered through. It's typically pretty well tolerated. And you are a little sore. The catheters are big. I think what makes you sore is probably us pushing on your groin for 45 minutes after we take the catheter out as opposed to the catheter. Yes?
What's the data beyond 2 years? Because your graph showed up to 2 years.
Right, so at the time of the completion of this study, there was 17 patients who were still undergoing treatment, and we have yet to follow up on exactly what happened to those 17 out of the 51. And the time frame for this population of patients was between 2008 and 2016. And then some patients were actually lost to follow-up because they were coming to both the UK or Moffitt from outside, and there was other treatments that were available locally. And so we didn't necessarily have the follow-up data beyond the 2-year time point for all of them. So it would be really difficult to say, and it's a small number of patients, so you can't really make large sweeping generalizations. But certainly that's something that needs to be followed. Anything else? Yes?
What's the scan protocol like in between treatments or?
So the treatments are done every 6 to 8 weeks. We typically scan you within that time frame between having your next therapy. If for whatever reason the 6 to 8 week period is going to be extended, then typically you get scans every 3 months.